Diabetes mellitus is one of the most complex and most common disorders in the nation, affecting nearly 16 million Americans. But many of them don't realize that they have diabetes. So the disorder goes unrecognized until the patient seeks care for another problem, such as blurred vision. Yet because diabetes can affect virtually all body systems, the patient runs a high risk of developing a life-threatening or debilitating complication, even before the disease is diagnosed. That's why you need to be able to spot the clues that point to diabetes. For example, this patient was just admitted to the emergency department. He's lethargic and confused, and his breath has a strong alcohol-like odor. Although you might think alcohol intoxication is the cause of this patient's condition, you should also suspect diabetic ketoacidosis, or DKA, as the cause. But do you know why? Can you relate this patient's assessment findings to the pathophysiology of diabetes? And do you know how your interventions can help him control the disorder? This video will help you answer these questions with confidence. It will clearly explain the pathophysiology of diabetes, show you how to identify and control the disorder, and demonstrate ways to recognize and prevent its complications. Diabetes mellitus is characterized by insulin deficiency, which alters the metabolism of glucose, the body's main source of energy. Before you can manage diabetes and its complications, you need to understand normal glucose metabolism. Normally, insulin is produced in the pancreas by beta cells in the islets of Langerhans. Insulin lowers the blood glucose in 3 ways. First, it shifts glucose from the bloodstream into the body's cells by binding to insulin receptors on the cell's membrane. Once bound, insulin and the attached receptor move into a cell, creating an entryway for glucose. Second, insulin promotes the storage of excess glucose. To do this, it activates the enzyme glucokinase, which breaks down glucose into glucose 6-phosphate, or G6P. Then insulin activates glycogen synthase. This enzyme converts G6P into glycogen, which is stored in the liver and muscles. Third, when the glycogen stores are full, insulin stimulates the enzyme lipoprotein lipase to convert excess glucose into free fatty acids. These fatty acids are absorbed by fat cells, where they combine with glycerol 3-phosphate, or G3P, to form triglycerides. 2 types of diabetes mellitus have been identified, but each develops differently. Type 1 diabetes is characterized by the destruction of all beta cells. In idiopathic type 1 diabetes, the cause of beta cell destruction is unknown. In autoimmune type 1 diabetes, the immune system recognizes beta cells as foreign and slowly destroys them. In both forms of type 1 diabetes, insulin production eventually comes to a halt. Without insulin, the patient develops hyperglycemia, or excess blood glucose. Type 2 diabetes is characterized by decreased insulin production, cell resistance to insulin, or both. Decreased insulin production usually occurs with age. In fact, the risk of developing type 2 diabetes increases with each decade of life. Insulin resistance occurs when insulin receptors have difficulty recognizing insulin molecules. As a result, fewer insulin molecules bind to receptor sites, allowing fewer glucose molecules to enter the cells. Several factors may increase the risk of developing insulin resistance. A family history of type 2 diabetes or an ethnic background that's African American, Hispanic, or Native American may increase the risk because of genetic factors. Obesity raises the risk because it increases the number of fat cells. And the receptors on fat cells resist insulin more than the receptors on other cells. A sedentary lifestyle can compound the risk because the patient doesn't gain the benefit of regular exercise, which lowers the cell's insulin resistance and helps prevent obesity. To compensate for insulin resistance, beta cells produce more insulin. At first, this helps glucose enter the body's cells, lowering the blood glucose level. Eventually, the beta cells become overworked and produce less insulin. This reduces the amount of glucose that enters the cells, causing the blood glucose level to rise. Without treatment, severe complications can occur. An acute complication, DKA, typically strikes patients with type 1 diabetes who don't take insulin as prescribed or who have an illness such as pneumonia. The stress of illness increases the secretion of hormones such as epinephrine, norepinephrine, and glucagon. These hormones raise the blood glucose level by increasing glucose production or reducing glucose movement into muscle cells. Then glucose builds up in the blood because it can't enter the cells without insulin. The cells soon become starved for glucose to fuel metabolism. So the brain signals the alpha cells in the pancreas to produce the hormone glucagon, which converts glycogen into glucose in the liver. When the glycogen stores are depleted, the liver converts free fatty acids and protein into glucose, raising the blood glucose level even further. The conversion of free fatty acids into glucose creates ketones as a byproduct. Because ketones are acidic, they disturb the acid-base balance when they accumulate in the blood. Eventually, ketone accumulation and hyperglycemia lead to DKA, a type of metabolic acidosis. If you suspect DKA in your type 1 diabetic patient, assess him quickly so that you can provide appropriate critical care. First, measure your patient's blood glucose level and repeat this measurement at least every hour until his condition is stable. In DKA, the glucose level may increase to 800 milligrams per deciliter or more. Also, check your patient's urine for ketones, which appear in DKA. Remember to recheck for them every 2 to 4 hours or as ordered until they're no longer present in the urine. Next, obtain blood samples to assess fluid, electrolyte, and arterial blood gas or ABG levels, which you'll review later. Then check for signs of fluid and electrolyte imbalances. You're likely to detect signs of dehydration, such as poor skin turgor and dry skin and mucous membranes. You're also likely to see signs of electrolyte imbalances, such as cardiac arrhythmias. In DKA, severe fluid and electrolyte loss usually results from osmotic diuresis. When the blood glucose level rises, the kidneys try to compensate by excreting excess glucose, which takes water, sodium, potassium, and other electrolytes with it. As large amounts of fluid move from the intravascular space into the urine, the blood volume decreases. At first, this hemoconcentration causes falsely elevated electrolyte levels. However, when the fluid is replaced, the blood becomes less concentrated. This makes the electrolyte levels fall, often to below normal levels. Next, take the patient's vital signs, being alert for Kussmaul's respirations. These rapid, deep respirations develop when the lungs try to remove excess acid by exhaling additional carbon dioxide. And because the acidosis is caused by ketones, the patient's breath smells sweet and like alcohol. Also check for low blood pressure and tachycardia. Low blood pressure results from low blood volume, and tachycardia occurs when the body tries to raise cardiac output while the blood volume is low. Now assess for signs of GI complications, such as absent bowel sounds, nausea, vomiting, and abdominal pain or tenderness. GI complications are common in DKA because metabolic acidosis slows intestinal function, which may lead to paralytic ileus or intestinal paralysis. When the test results are ready, check the ABG levels. DKA typically causes a partial pressure of carbon dioxide, or PCO2, of less than 35 millimeters of mercury, indicating the lungs attempt to compensate, a bicarbonate level of less than 28 milliequivalents per liter, indicating the kidneys attempt to compensate, and a pH of less than 7.35, indicating acidosis. To treat DKA, first replace the lost fluid with normal saline. Administer each liter over 30 to 60 minutes as prescribed. During fluid replacement, recheck the electrolyte levels every hour and administer specific electrolytes as needed. If your patient's pH level is below 7, start a bicarbonate infusion as prescribed. To prevent rebound alkalosis, be sure to infuse it slowly. To lower the patient's glucose level, expect to administer insulin intravenously. After administering a bolus of regular insulin, begin a continuous infusion of 0.1 to 0.2 units per kilogram per hour based on the blood glucose level. During insulin therapy, monitor your patient's glucose level closely. Make sure that it doesn't fall faster than 100 milligrams per deciliter per hour, because this can cause complications. How? As glucose moves from the blood into the cells, it takes water with it. This may cause cellular edema and organ swelling. If swelling affects the brain, increased intracranial pressure may lead to herniation and death. Also, watch for early signs of hypoglycemia or low blood glucose, such as diaphoresis, tachycardia, and tremors. In this dangerous complication, the blood glucose level falls below 60 milligrams per deciliter. When intracellular glucose levels fall, the brain signals the alpha cells in the islets of Langerhans to secrete the hormone glucagon. Glucagon causes glycogenolysis by triggering enzymes to break glycogen into glucose. Glucagon also causes gluconeogenesis by stimulating the conversion of protein and free fatty acids into new glycogen. The brain also signals the adrenal glands to release epinephrine, which prompts the breakdown of glycogen and fats to glucose. The release of epinephrine causes the early autonomic signs of hypoglycemia, such as diaphoresis, tremors, and tachycardia. If the blood glucose level continues to fall, the patient develops late neuroleptic signs of hypoglycemia, including poor coordination, slowed thinking, and loss of consciousness. If your patient has hypoglycemia, is conscious, and can swallow, provide 15 grams of an easily absorbed carbohydrate, such as 4 ounces of orange juice. Repeat this treatment every 15 minutes until his hypoglycemia resolves. If your hypoglycemic patient is unconscious or can't swallow, administer 25 to 50 grams of dextrose 50% in water by IV bolus. If he doesn't have an IV access device, inject glucagon intramuscularly. Remember to turn the patient on his side to prevent aspiration, because glucagon can cause vomiting. To prevent hypoglycemia, change the IV solution to dextrose 5% in water and half normal saline when the patient's glucose level falls below 250 milligrams per deciliter. If your patient with DKA has abdominal pain, nausea, vomiting, and absent bowel sounds, give him nothing by mouth, and prepare to insert a nasogastric tube to relieve distension. Once your patient's condition is stable, perform a complete physical assessment. First, obtain a full description of his symptoms. Your patient is likely to report polydipsia, or increased thirst, polyuria, or excess urine output, polyphagia, or increased hunger, and weight loss. All of these classic effects of diabetes are caused by hyperglycemia.